Well, essentially, I'll follow up on the discussion of the last two speakers. And clearly, there's a distinction in my mind and in the literature on which particular asynchronies have the potential. And I think that was an important point that Jeremy made, because I have breath stacking, once every few minutes. Does that have a clinical impact on a patient? Whereas if I have 700 in an hour, obviously there's going to be a potential for a very negative impact on a particular patient. My disclosures, although I have relationships with industry, I will not be talking about any particular products. So let me begin with just the classification that I use to organize different types of asynchronies. And I've highlighted the ones that, at least in literature and based on a physiologic perspective, would seem to be the ones we should be most concerned about creating lung injury and a poor outcome in patients. And that's flow asynchrony, that's double triggering, breath stacking, reverse triggering, whatever term you want to use for the particular subcategory, where you have breaths that are clearly larger than what you anticipated that breath to be. And of course, there's some data about mistriggering, particularly the concept of clustering of mistriggering, and probably something we need to look at with all of these asynchronies is the frequency with which they occur in a short period of time, and whether that is related to the outcome of patients as opposed to just the random frequency over a longer period of time. I'll give you my perspective on modes of ventilation, because I agree, mode of ventilation can have a huge impact on the level of asynchrony that develops. And if you've ever yourself ventilated on a mechanical ventilator, put a mouthpiece and a filter on and breathe through the ventilator, what I think you'd probably agree to is that the ease with which you can acclimate to the ventilator is associated with the amount of control the ventilator exerts over your ventilatory pattern. None of you sit here and breathe with a tidal volume of 6 ml per kilo every breath, with an inspiratory time of 0.8 seconds, with a respiratory rate of 16 per minute, with a peak flow of 40 liters per minute. Every one of you have a lot of variability, even during the resting state. So a mode of ventilation that dictates all of those variables, the probability that the patient will not tolerate that, as well as one that gives a patient the flexibility of making the choice on how the breath is delivered, will be associated with the amount of asynchronies. And I put volume assist control at the top, because we have 3 control variables. We control volume, we control flow, we control time. And as you note, PAV and NAV at the bottom, because those are all patient-controlled breaths. Yes, there are asynchronies, but clearly, as you look at comparisons, not as many as in the classic modes of mechanical ventilation, where the patient really determines the process of gas delivery and the ventilator follows the lead of the patient. So the first one, as John Rainey published back in high school, I think it was, this study, looking at flow asynchrony in volume-targeted ventilation. I think we forget the fact that this is not an uncommon occurrence, that flow asynchrony, particularly in volume ventilation, if we choose small tidal volumes, and we have a patient with a significant ventilatory drive, happens very frequently. And obviously, if you look at the waveforms, it's pretty easy to pick out in a given patient. I mean, it can be in any part of the breath, but the classic would be at the onset of the breath, that the patient's triggering effort, that the patient's inspiratory demand exceed what you set on a mechanical ventilator. Not uncommon if we're setting a very low peak inspiratory flow rate and we have a patient with a high demand. So I would go to this study of Yoshida's that was published about a year ago, where they looked at patients and an animal model of to try to assess the level of pleural pressure change when a patient or an animal with an ARDS, a consolidation, is breathing forcefully, and looked at a comparison between sedation or paralysis without any ventilatory effort, and then circumstances where the patient was breathing spontaneously, in volume assist control and pressure assist control. They did this by putting normal esophageal balloon in, and in the animals, they put wafers at the most dependent part of the lung and at the least dependent part of the lung, so that they get a spectrum of what the esophageal pressure change was from non-dependent all the way to dependent, and looked at the distribution of ventilation by region using electrical impedance tomography. So if we look here at the illustration that they have in the paper, all the way to the right, all the way to the right you have the control breath. And what I would point out, as we expect with controlled mechanical ventilation, the most dependent part of the lung usually ends up with the lowest volume. The non-dependent part, because of the difference in compliances, has a larger overall tidal volume. When patients were allowed to breathe spontaneously, here in volume assist control and in pressure assist control, notice the penduloof that exists between the non-dependent and the dependent lung. The dependent lung, as you're well aware, as we breathe spontaneously, the vast majority of the volume moves to the dependent lung as opposed to the non-dependent lung. But they demonstrated in this animal model of ARDS that the majority of that volume was a result of penduloof coming from the non-dependent area to the dependent. As you'll notice, there was no increase significantly in volume during the inspiratory phase. The red line represents that period here in volume assist control and here in pressure assist control. Similar phenomena in both modes of mechanical ventilation. I mean, the perspective that was had before is, with volume ventilation, we will not have a significant alteration in transpulmonary pressure, because if the patient pulls more, the ventilator needs to push less to get into desired tidal volume. Well, they found that that was not true as you looked at patients actively breathing if you look at measurements of pleural pressure changes in different locations in the lung. This represents the pleural pressure change at the base of the lung. This represents the darker line here, the pleural pressure change, looking at a typical esophageal tracing. So in these animals with consolidated ARDS, there's a huge difference in the amount of pressure developed in the dependent compared to the middle portions, if I can use that term, of the lung in looking at esophageal pressure, which was totally eliminated as they sedated and paralyzed these animals. So we can get this maldistribution and the same phenomena of huge intrathoracic pressure changes and big transpulmonary pressure changes that, as we know, are injury-inducing anytime we have a level of flow asynchrony. Obviously, the more effort the patient's putting forth, the greater the potential for those different pressures to exist. Double triggering, we heard a lot about double triggering already, and I agree 100%. This is a phenomena that we should be looking for. We should be doing everything to correct it. This is from Louis Blanc's lab in Barcelona. I had the privilege of working with him on this study. Looked at a series of patients in different approaches to gas delivery. Volume ventilation with the square wave flow pattern, volume ventilation with the decelerating flow pattern, and pressure control, assist control ventilation. And we noticed that regardless of what approach, we saw patient-initiated by ventilatory demand double triggering and reverse triggering. Every single patient that we studied in this population, we saw both of these. 67 patients, you can see the distribution of those patients' diagnosis. They were not all ARDS patients. Only 7% were ARDS patients, but 70% were acute respiratory failure patients for multiple reasons admitted to their ICU. We collected greater than 8,000 hours, 7 million breaths, and this was on average for all of the patients over the full course of mechanical ventilation, that 0.6% of the breaths were double triggered, with about 1/3 of those being reverse triggering. Again, in every patient, we saw both phenomena, the typical double triggering and reverse triggering occurred. This is all 67 patients, and of course, these were the ones that had the high levels of concern of double triggering. So in that population of 67, for sure, 3 patients had very significant levels of double triggering or reverse triggering. This was the average number per hour across the full period of time that those patients were mechanically ventilated. These are 2 individual patients, and you can see the time periods where we have these huge clustering of double triggering that occurs, with other times where very little double triggering occurred in these patients. Others where it was a pattern that continued unrecognized, untreated throughout a longer period of time of their mechanical ventilation. If we look at tidal volume and peak pressure, in both volume control, pressure control, and volume control with decelerating waveform, we see that increase in volume during those double triggered breaths, particularly in volume ventilation, simply by the way the machine functions. If I deliver that second breath before the patient begins exhalation, I can expect that the total volume that that patient received is about twice of what you set as a tidal volume. Pressure control, the tidal volumes are a little smaller because the airway pressure is set by you and it doesn't go over that level. So if I've already filled the tidal volume, the secondary increase ended up being a little bit smaller than what we saw in the pressure targeted. But in volume ventilation, clearly increases in the pressure as we looked at the double triggering or reverse triggering. Here is a comparison of double triggering and reverse triggering. And as you can see, in most circumstances, there's statistically significant differences because of the number of breaths. That very small differences end up to be statistically significant. But I would say that in most circumstances, the difference was equivocal from a clinical perspective. That whether you had reverse triggering or you had double triggering, you had significant increases in overall tidal volume. So clearly this can be problematic. As we looked at our data, these were the variables that were associated with double triggering. Now, tidal volume, as Jeremy said, did not fall out. Although these patients had a pretty uniform tidal volume. We didn't have extremes of tidal volume being delivered, so I wouldn't expect that tidal volume would show up as a predictor of double triggering. But short inspiratory time, low peak inspiratory flow rates, high respiratory rates, greater dynamic compliance, which was something we did not expect to see. Patients that had a higher dynamic compliance had a higher frequency of double triggering. Jeremy presented the published version of this paper. This was the abstract that he presented at the ATS. And I use this as an example because of the frequency that they indicate of double triggering that occurred in these patients. From 0.1% to 90% of the breaths were double triggered in this population of 20 ARDS patients. They also showed a difference in survival based on what the frequency of double triggering was. In the patients who survived, a relatively low frequency. In the patients who didn't survive, a high frequency of 19%. In 40% of the patients, greater than 10% of the breaths were double triggered in this population of 20 patients. I would expect potential for significant adverse impact when I have that level of double triggering occurring throughout the whole period of ventilatory support. Mistriggering, as we saw before, very common in the chronic obstructive lung disease, very common in any patient we create air trapping in. And I would refer you to this one publication that looked at the clustering of those events. When they looked just at the frequency of mistriggering over the length of mechanical ventilation, they did not identify subpopulations that had a higher mortality. But if they looked at clustering of it, and their definition of clustering was 30 mistriggers over a 3-minute period. So a asynchrony index of about 35%, which occurred in 42 of the 110 patients they looked at. Those patients were associated with a lengthy period of mechanical ventilation, as well as an overall increase in mortality in that population of patients. And this is an illustration of it, that patients had missed triggers all along the line, but there were these periods of time where in a 3-minute period they had greater than 30 missed triggers. We have not looked at this in other asynchronies, at least none that I'm aware of has been published. We're taking a look at our data and reanalyzing it to see if there's a signal with clustering of other types of asynchronies and whether or not they predict a poor outcome, as in this case. So I leave you with asynchrony is common in every patient we mechanically ventilate. You'll find some level of asynchrony in every patient you're ventilating. Most it's going to be infrequent and probably has no overall impact. Others, it can have a very significant impact. And to answer John's question earlier, there's no doubt in my mind the way we set the mechanical ventilator, the mode we choose, the peak flow we set, the inspiratory time we set, all of those factors play into whether or not asynchrony will occur in any given patient. It's been associated with increased length of time mechanical ventilation, increased length of time in the ICU, and as I indicated, increased mortality. Thank you.